We are about to unlock access to insulin. Plenty of seats at the front. I won't scare you, I promise. Come on and take a seat. Welcome, everybody. So good to see you. Unlocking access to insulin, brought to you by the Helmsley Charitable Trust and Access to Medicine Foundation. Moderated by me, Femi OK, attended by you brilliant attendees. Thank you for being here. You could be anywhere in Geneva, but you're in this dark space because you are truly committed. And I salute each and every one of you. Thank you for doing that. All right, pop quiz to make sure you haven't fallen asleep after lunch. What was invented, discovered in 1921? Hands up, stand up, first answer. Who? Stand up. I know you have the answer. Hand up. Great, stand up. All right. Hand off mic is needed immediately. Is this on? Perfect, all right. What happened 1921? First answer.
The discovery of insulin, I think you're referring to.
You sound so unsure. Let's try that again. What happened in 1921?
Discovery of insulin.
And the crowd goes wild. All right, so we have a prize. And the prize is, do you have a phone? Yes. All right, point your phone at the little card on your table, and it's got a QR code there, and you can be the first person to get a digital report. And it's always great to be a pioneer. Congratulations. All right, so I'm pretty sure everybody in this room knew that answer, because if you don't, leave. Today we are delving into the challenges that come from the supply and demand of insulin. We have expert guests who will do that for us. We have expert audience, as you can tell from that immediate pop quiz. And you can speak to our supply panel. You can speak to our demand panel. That conversation goes from here and back and forth. So be thinking about what questions you might want to ask the panelists. I have a couple of words in my mind, and that's really to guide our conversation. I'm thinking about progress, unlocking access to insulin. I'm thinking about initiatives, and I'm thinking about solutions. I'm giving those three words to you because that's how I'm thinking about how we're framing the next 90 minutes. But first, Claudia Martinez is the Director of Research at Access to Medicine Foundation. I know she knew that 1921 answer, and she has so much more wisdom to share with you. Claudia, welcome.
Thank you, and good afternoon, everyone, and thank you to Femi for the very energetic opening today. Very happy to be here, very happy to be in this room with so many familiar faces, to have this very important discussion on how to unlock some of the challenges that we see in equitable access to diabetes care, particularly in low and middle income countries. As many of you would know, the Access to Medicine Foundation is an independent, not-for-profit organization, and our mission is to mobilize companies to really bring essential healthcare products to the populations that need them most. And since 2021, we have been working on a dedicated program focusing specifically on access to diabetes care, looking all the way through access to insulin, access to monitoring devices, really looking at the barriers and how different players can help unlock some of the gaps. And today, I'm very excited to share our newest report. As Femi said, you can access it by scanning the QR code on the tables. But we are looking specifically at access to insulin and diabetes care products for children and young people living with type 1 diabetes in low and middle income countries. And this is a group that often faces some of the toughest, most critical challenges in accessing the care that they need. We do know that managing type 1 diabetes is difficult, right? But for children and young people living in resource-limited settings, it is often not just difficult, it's also a matter of survival. And we do know that far too many people today do not have access to insulin and some of these other important healthcare commodities. So to put this into perspective, in 2024, around 1.8 million children across the world were living with type 1 diabetes. And still, more than 30,000 of them, under 19 years old, died from a condition that we know how to treat. And nearly 40% of those deaths actually happened in sub-Saharan Africa, which is the region that stands to lose the most and where we do see some of the highest burden and prevalence. But there's also good news, right? And I think today something that we're going to be discussing on the panel, and I'm very much looking forward to the conversation later, is some of the solutions that we're seeing come forward. I think we are at a point where there's incredible innovation. We have better insulins, we have glucose monitors, we have smarter delivery devices that are already changing the lives of many people across the world. But now we need to ensure that these advances are not widening some of the gaps, but actually helping close them. And this is where the report comes in. So we profiled and we identified 11 unique initiatives that are actually working to close some of these gaps for children and young people in low and middle income countries, led and supported by 4 of the companies that you will be hearing from today. And these initiatives are quite unique. In many cases, we know that they may be the only available support that many of these children will have in many of the countries. They are heavily focused on focusing on the needs on the ground of some of the partners, working in partnership with local systems, but also they have broad coverage. So across the 113 countries that we looked at, they're operating across 71. And also they are providing far more than just insulin. Very often they also come with delivery devices, monitoring devices, education, peer support, and even infrastructure investment that we know is so critical to actually help some of these systems grow and develop. But we also know that we have challenges, right? Even though we're not starting from zero and there's a growing base of experience, collaboration, we also need to think about how do we go from here. Because as vital as these initiatives are, they're still only able to reach a very small proportion of the number of children and young people in low and middle income countries that actually need support. Very often, they remain heavily reliant on donation, whether this is financial donations or product donations by some of the companies that are supporting them. And they also have very often age cutoffs where we do know that once you hit 21 or 25, the transition into adult care can be extremely challenging. So we believe that this moment really presents an opportunity to build on what's working. We know that the 11 initiatives that we analyzed come to show that the partnerships between the companies and some of the local actors are actually powerful vehicles for change, but they need to be backed by sustainable access strategies. We need to see, and I think this will come out in some of the discussions today, stronger integration within primary healthcare systems, as we know that that's the first place where people seek treatment. We also need for governments to continue prioritizing non-communicable diseases and particularly diabetes within their national health strategies, their procurement, and also their supply chain strategies. This means also thinking about collaborative long-term solutions that actually help transition from donation-based models into more sustainable systems, as we have seen in many of the countries. And this is heavily profiled in the report, where governments might be ready to take on some of the supply and reimbursement and work with some of the companies to be able to make this a reality. And at the same time, we do need companies to continue to sustain and expand their efforts. So not about just continuing some of the existing programs, but continue to deepening some of the collaborations, thinking about product affordability, and also continuing to invest in the locally owned solutions that will help actually bridge some of these gaps for the long term. So we have the tools, we have the knowledge. We're very pleased to be here today. I'm very much looking forward to the panel and today's discussion. I think we do have the right players in the room to come up with the solutions that we need. So thank you again, sincerely, on behalf of the Access to Medicine Foundation, on behalf of the Helmsley Charitable Trust for being here, and I look forward to the conversation ahead.
I am going to welcome to the stage our supply panel. My seat is that one that's right over there, closest to the flowers. Anywhere else, panel, you can sit. All right. John Fairest is the head of Medical Global Health Unit at Sanofi. Hello, John. Please come and take a seat. Robert Lloyd is the Associate Vice President of Social Impact at Lilly. Hello, Robert. Please take a seat. Carissa Vados is the Head of Diabetes Health Equity at Novo Nordisk. Hello, Carissa. And Rhonda Duffy is Chief Operating Officer of Biocon Biologics. Welcome, Rhonda. So I couldn't help but notice, hi Rhonda.
Hello, how are you?
That these are the biggest companies involved in the world in supplying insulin to the international community. How often do they get together? Pretty much never. So it's extraordinary. John, why are you here? In 30 seconds.
Why am I here?
Yeah.
Because I was invited nicely by the Helmsley Trust, that's the first thing. And I knew I'd get a free lunch.
No such thing as a free lunch, John. We're making you pay for it now.
Actually, you know, I keep coming to these events, and I keep speaking, and I keep coming every time because I want action, not just talking. And every time I come, I hope that we're going to walk away with some real action. That's why I'm here.
Oh. Well, that's a hard one to top. Rob, why are you here?
The free lunch, but no. You know, if you think about the big scourge of diabetes and how there's such an opportunity for us to come together and unite around solving the solution, providing solutions. But it's not just the pharma companies, it's people in this room that can help us do that. You know, whether you talk about governments, regulatory agencies, NGOs, you know, access, those who are in charge of access. So it takes a village. And that's why I'm here today, just to, you know, we're doing our part or what we're doing, but we're going to need help from others. So spread that message.
Thank you, Robert. Carissa.
I'm going to go with a metaphor that may or may not work, but I'm here because I want to hone my surfing skills. So I think there's been a tremendous amount of momentum in the access to insulin area for quite a long time. But for better or for worse, there's a bit of a tsunami at the moment, in a good way. And I feel like I'm really excited to be part of trying to ride that and trying to capitalize on that change momentum with all of you, because the equity gap in insulin access is unacceptable, and we have to work together to close it.
Sure. Rhonda.
Insulin is a foundational product for Biocon. Kiran Mazumdar-Shaw, our founder, when she realized that India did not actually have recombinant human insulin, that it only was animal origin insulin, she set it up in 2004. So we're a new company to the whole insulin one in comparison to some of my colleagues here on the stage. But it really is foundational, and it's one that we really want to make that affordable and accessible throughout the world. That's really our mission in life.
Oh, goodness, affordable and accessible throughout the world. Wouldn't that be amazing?
Yes.
Like, truly, truly amazing.
Yeah.
All right, John, Sanofi has been trying to make access to insulin more equitable. How is that going? What do you want to share with us about that progress?
It's not as fast as it should be. I think it's wonderful you've got the three companies sitting here at the table, because I think the first thing I'd like to comment on is that we need to get rid of competitiveness and do this together. So, you know, we're all sitting here discussing the same topic. It's fine. Sure. I think one of the things that we've learned straight away is, and I'm sorry if I'm repeating what I said on an earlier panel this morning, but we need to build some capabilities and understanding first to create, I know there's a demand panel coming, but so people understand how to use insulins, particularly in low and middle income countries. And that's something that will help drive a demand which will create a necessity more for people to actually have access to products. We need capability building at community healthcare worker level and specialist level. The second big challenge for us has been around regulatory process. We have an impact brand of Glargine, and you would not believe I have 450 regulatory processes across the African continent just to change a name on a box from when the product comes from the same factory. And this is things that we need to drive change with today. So this is, and we work now working with the African Medicines Agency to move this along. And we're making progress. We don't give up. We fight for these things. The third thing is around, I would say, guidelines as well. You know, to be on pre-qualification lists, to be in the guidelines in the first place is a bureaucracy challenge. And I think we all as companies face this, and we want to try and accelerate how we can work together on that. And then these guidelines need to be rolled out effectively. Because once the guidelines are rolled out effectively, you get governments on board. Straight away you realise this. If a government buys into guidelines, which we find, you immediately get that acceleration. And then the final piece is really probably what you're going to talk about, is really supply chain. How do we get better at cold storage? How do we get better at having products of proximity to patients? And you know, you can get an ice cream to somebody or a can of Coke to somebody in the middle of nowhere. Can you get a box of medicines or a syringe of insulin? It's totally different. So these are how we got to partner and think about how we do that, and the opportunities are out there to make that happen.
So John, you just gave us the challenges. You didn't give me any solutions. Do that list again and tell me how you're fixing it.
Oh. So I'm writing the script now for everybody else here, so this is fine, yeah? So the solutions are, we do training programs with governments and NGOs, and we work together in collaboration with other companies now, and we're training tens and tens of thousands of community healthcare workers to understand how to manage diabetes. The second point was on the regulatory process. This is really something that we are actually teaching and using our regulatory teams to go to countries, go to the African Medicines Agency, and show them how to be more efficient in terms of regulatory process. We even take our regulatory people from countries to our factories now to show them that we actually really do make the product in a high-tech plant. So that's the other thing. And I think the distribution piece for me is really about finding new innovative partners, and we're doing that. We're trying to find, we invest in startup companies in the supply chain now to understand how we can get faster access to products. Does that help a little bit?
Oh, that's good. Do you know, it's so good that when John started to do solutions, Robert got out his notepad from Lilly and wrote stuff down.
I'm glad I went first.
It's this international pharmaceutical espionage happening in front of our faces. What did you write down, Robert?
I wrote down everything he said.
There's a copyright, by the way, on all of this, I'm just saying.
I like to think of this as collaboration. Robert, go ahead. What resonated for you?
No, I think if you look at solutions, I'd like to maybe provide an example.
Sure.
You know, diabetes has been in the heart of Lilly for as long as insulin's been around. But we recognize more needs to be done to make access to affordable quality insulin, especially in low-income countries. And so in 2022, we established a collaboration with a pharma company, Ever Pharma, in Egypt. We recognize that some of these local companies that are closer to the markets know the markets better than we do, have better networks and systems to reach the patients. And so we embarked on this collaboration to do a tech transfer, so teach them how to make insulin, and supply them the active pharmaceutical ingredient at cost. Okay, so they could produce insulin at a low cost and then supply into these markets. I'm proud to say that within 2 years of signing that agreement, so an empty warehouse, okay, they have got approved in Egypt both human and analog insulins. Okay. They are now working through that process to get that insulin into other markets on the African continent. Now, one would think, and that's why I wrote it down, one would think that would be an easy process, right?
Sure.
Okay.
Yeah.
But that's where the challenge really comes in. You know, a vial of insulin is only a vial of insulin if it gets to the patient that needs it. Tech transfer is probably the easy part. Getting it to the patient is a challenge. So this is where And I appeal to people in this room today. This is where you need to address the challenges that we face from a regulatory point of view, the regulatory systems. I mean, we've made tremendous progress. The WHO, the pre-qualification, the API, IMF pathway has been a huge step forward. But regulatory harmonization, reliance-based pathways, you cannot go and register a product in 55 countries on the African continent and maintain those registrations for eternity. It's just not viable. Besides that, there needs to be good demand. If you're running a manufacturing plant, unless you have predictable, reliable demand for that product, you can't run a factory efficiently. And to bring down those costs, you need to be able to do that. So the demand piece, I look forward to hearing the next panel discussion on how we can ensure that, that insulin that's made in Africa is bought in Africa for Africa, and not if it's available for a penny less somewhere else. So that's very important to maintain that efficiency and the cost structure. And then the last one is probably a lot of people in this room work on it, the healthcare, the diagnosis, the access to healthcare, the treatment, the training, especially at primary care level, is so important to make sure that when the insulin gets there, the right patients get it and they take it correctly to make sure they could live a quality life.
Chris, I'm thinking about tech transfer, and it's something that you know a lot about in terms of what is happening between your company and working in South Africa. Can you tell us that, unpack that for us a little bit more so we understand how that helps us get to progress for more accessible, affordable insulin?
Absolutely. Thanks for asking. And I think the Eva Pharma example is actually really inspirational. The one that we have is with Aspen Pharmacare in South Africa. And it was a deal we announced in September 2023. And the goal there is to provide more quality insulin that's locally made. And ultimately, when we think about access to insulin at a market level, it's also to try to improve supplier diversity. And I won't drill into the Aspen deal specifically. I think it sounds like yours is going really well. We are getting there. And we hope that the ambition is to have insulin for the continent in the millions at some point. But the point about the supplier diversification is quite important. Is what we have seen, with us sitting here is in a lot of low and middle income countries, one of us dominates the market disproportionately. And we, visually, this is like a very, very tall building with one structural beam at times. And so if something goes wrong, either a supply issue or you make a change to your portfolio, it means that you've destabilized that system. So something we're really keen to do is when we think about, we think about health equity and access in the pipeline, in our commercial strategies and in market. At the commercial strategy level, we really want to think about how can we be a player in improving market health. And I hope we pick up on that theme a little bit, but that's quite important. So local manufacturing, tech transfer is part of that, as well as a lot of other ingredients.
Is that then prioritizing people who need insulin rather than the profits of the companies who produce it? If we're going to be really candid here. And is that a sustainable business model or even approach?
It's a great question. For us, it has to be sustainable. But I think a simplistic way of thinking about it is there's two ways to do that. So the direct way is to have integrated business models. So that you can do at the commercial strategy level or you do in country. So we have an integrated business model that the Access to Medicine Foundation featured in the Access to Medicine's index reports called iCare. It's in our Middle Africa area. It covers 49 countries. Essentially, what we do there is we balance volume and value, and we have a business that works, but that actually reaches more than it would if you just had a sort of traditional, very high margin type business. So it's important that we have that dynamic in play. And then we have the indirect, and that's about strengthening the health system. Ultimately, we make innovative pharma products. So the healthier the health system is, the more likely those products will get to those who need it. So then we have programs like Changing Diabetes in Children, which is something that's been running for 15 years, a big global and local partnership. That is all about making sure the health system is stronger in delivering, in this particular circumstance, type 1 care for children. So it's a bit of both. It has to make business sense. We're a business at the end of the day, but there's really creative ways of making sure you can do that. And the partnership piece is really important when we think about markets in low and middle income countries.
John, you're staring at me. What's going on in your mind?
No, I'm just gaining every bit of knowledge from you here, and it's interesting how we're all trying to do the same thing, but we have some common approaches, but we're doing different things in many ways. And I think this pricing question is a really interesting one on how we manage that and how we look forward, and how equitable access is something we've got to. I think we're all struggling a bit with, and on the affordability piece. And I think it's something that we are making advances on. You've chosen to do it with tech transfer. We're investing $1.3 billion in Frankfurt to make sure that our factory continues to produce more efficient quality insulins at a cheaper price. So I think the pricing piece is something that I think is really interesting between us all. We're not allowed to sit in a room and discuss pricing because that's anti-competitive. But it's an area where I think we've made massive inroads. But we have to make the healthcare system think about investing in insulins as an investment, not a cost. And the final point on that is, I think we're all probably talking a little bit around second generation products here as well. So we're modernizing innovation. And innovation is absolutely crucial for what we're trying to achieve here. We want to provide innovation in low middle income countries. It's crucial for patient treatment. And that's the bit, if you talk about unlocking pricing, is where we're chasing.
Rhonda.
Yes.
You come to this conversation a little bit differently, right? Do you want to explain how different?
So I'm the Chief Operations Officer. So I'm the person who actually has the best job in the company entirely. I manufacture the product for the patient. So it goes from the hands of my team to the patient directly. They get what we make as such. So all of the conundrums and complications associated with what's happening out there in the marketplace, it really comes down to, okay, can I actually make the product and get it to the patient on time, in full, that reliable, predictable supplier? The manufacturing sites within Biocon are either in Bangalore or in Johor in Malaysia. So we're in those low-cost countries as such. The facility in Johor in Malaysia is actually our centre of excellence for insulins. And currently I'm doubling the capacity there. In India, I'm also increasing the capacity by 50%. All of those will trigger regulatory changes and all the rest of it, but I can actually reduce the cost of the insulins I manufacture by of the order of 50% over the coming 2 years. And that really is my contribution to what is it that we're actually doing. How can I actually get that insulin to the patient reliably and at a cost that they can actually afford? It requires a lot of change, everything from the yield associated with the cells that we're actually growing to the pen that we actually put it into, to the transport systems. When I make a batch in Malaysia, it's a great location. It's just over the bridge from Singapore, so you've got that big port and hub. But I need 3 aeroplanes to take one batch of the product. So it's not a case of, it's just a simple job. I remember one of my colleagues in a previous role asking me to do something that really required a few miracles along the way. But his question was, Rhonda, how hard can it be? Believe you me, it can be extremely hard to manufacture an innovative recombinant product and deliver it to the patient in a cold chain setup as such. And that's when we actually deliver it as either a pen or a vial in terms of that. But I also deliver drug substance around the world as well, between Bangladesh, Egypt, Mexico, various locations in South America as well. Again, my job is to actually get that to a reliable fill-finish facility partner that we can actually make sure that the patients in Mexico can actually get their insulins as such. And then a large part of where I am at the moment with the whole tech transfer side of things is actually local manufacturing. And again, that's bringing the expertise and the knowledge that we actually have in being able to manufacture the product to the location. Typically, it kind of works backwards. You start off with doing the packaging operation there. Then you bring it back to the actual aseptic sterile fill finish. Remember, all of these products must be injected into somebody. This is not just, put a few things together, stir them about, and actually put it into a bottle, and away you go. This is high-tech stuff. Finally, having the equipment and the facilities in order to do it. You don't actually have a sterile fill finish piece of equipment sitting on a shelf. I'm over here in Europe quite a lot, even though I'm based in Bangalore overall, because we do buy the German equipment. That is important. But right now in Germany, with the manufacturer that I have, 25 months is the lead time in getting one of those equipment from them. And then it takes a good 18 months before you actually have it qualified in place and the authorities have actually approved that. So essentially you're looking at the order of 3.5 to 4 years before you actually have those equipments. I'm also helping in those local manufacturing places, which equipment should they actually buy? How should they actually go about setting it up? And providing my manufacturing science and technology team to them in order to actually start that local manufacturing in the area. I will say that the facility I visited a few weeks ago, who are manufacturing the aseptic sterile filling equipment, they went, big shop floor, like it's a kind of, huge big warehouse sort of area, and they went, Novo, Lilly, Novo, 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 as they were actually looking the equipment that was on the floor. So we all know who the big players actually are in it, and my equipment, if I buy from them, will be 25 months hence from now. So it is what it is, but it's that whole back part of how you actually get product to a patient. And right now, cold chain is not the easiest one. COVID was interesting, but we had the Houthi guys on the Suez Canal, the pirates, trying to actually prevent the boats going up and down, so we had to go around the Cape of Africa instead when you send it by boat. That actually tied up, 12% of the containers that you can actually put cold chain into. So it was actually not even could I get airplanes, could I get a boat, it's could I get the cold chain containers in order to actually bring it around the world. There are many things that impact. No-fly zones over the war zones, and we have a few war zones around the world as well. Raw materials coming in from the other side of the Panama Canal, no rain, the Panama Canal water level dropped by 45%, so the boats couldn't make it through. The challenges of actually getting the product to the patient can be sometimes quite challenging. And I haven't got a total solution yet other than 3 aeroplanes.
I'm going to open up the room to questions so you can talk to the supply panel. We have 2 microphones. Where are the microphones? All right, let's get the microphones ready. I'm going to ask one more question, if I may, and then please put your hand up high so the microphone will come and fly into your hand. So my question is to our supply panel. Do you have a team that basically looks at the challenges and finds the solutions? Is there a department of what the hell? And then they come up with, Eureka, we found the answer.
It's me, okay? It's all of mine. So honestly, I am actually trying to get my insulin supply to India sorted out during the day today.
What's on your phone? Why are you looking?
WhatsApp. WhatsApp is the way we actually communicate. So am I getting the supply out? Is it actually happening?
Sure.
Have I pushed hard enough?
Right. Robert, does that department exist?
So I wouldn't say we have an exact dedicated, is my mic on? A dedicated team, but certainly, when these challenges come up, groups get together to solve them. And sure. Maybe as an example would be, we work on not only healthcare strengthening with programs with UNICEF, which is a great example, but also we work very closely with an organization called Life for a Child, where we, since 2009, have provided about 8.1 million vials of insulin free of charge to distribute to children around the world in low middle income countries. And coming back to the logistics, this is a challenge. And we currently sit in about 56,000 kids. We want to get that to 150. But getting to 150 is not so easy. And we discovered, as we wanted to transition from providing human insulin in vials to where we are now, providing cartridges in pens, analog insulin, both rapid and basal insulins. It's not so easy getting it to them. And the cold chain is a big challenge. So when that challenge was presented to us, the team got together and we worked on a solution, partnering with Direct Relief, to actually buy, cost about $6.5 million, refrigerators to station along the way for these partners so that that insulin quality was never compromised to get it there. But that's a huge undertaking. That's just a small piece. Can you imagine when you multiply that? That's just one program. When you multiply that by all the insulin going around the world. So, where there's a problem, we try and step in to solve it as best we can. But I'm sure many more exist and many other solutions exist with other companies to try and address this issue. But it's real, and we do have people who think about it and try and address it, yes.
Excellent. I want to share the conversation with our attendees.
Hello, everyone. Thank you very much for the very insightful information that I personally, as an adult person, care to hear. But Femi, you didn't ask me why I'm here. I want to say I'm here to be the voice of the people living with diabetes. And I want to ask you, all of you, what do you think a child in need of an insulin injection would think of the supply chain, the cold supply chain, the percentage of the higher cost of insulin, which we, I'm sure, understand, but how do you explain that to a child in need of an insulin injection? And I don't mean it in any negative connotation toward any of you. We thank you. We appreciate the work you're doing in providing at least the existence of insulin. But if I want to go back to the founders of these prestigious companies, I remember, for example, reading a book from Eli Lilly. His vision wasn't to have an expensive insulin in the market. So what happened to that vision? Where are we today from the vision of Frederick Banting and Dr. Best, those who invented the insulin? And by this, I want to be completely honest in voicing out the need and those underprivileged where their life is pending from one word. That word is insulin. And we're today talking about access. So please let us know, how do we get to that access situation where 100% of the people living with diabetes don't need to think about access, and they have it. Affordable, available, and they can get their insulin injection. Thank you very much.
Who would like to take that on first?
I'm happy to. Yeah, and sorry, I didn't catch your name. Jackie, nice to meet you. I think it's a point very well made, and the report that Claudia referred to, I read it last week when it came out, and the stat you didn't mention, you mentioned that the efforts that the companies are making are reaching over 70 countries within the LMIC, but are not reaching a significant actual number of children and young people. And I'm pretty sure the figure is 8%. Right? So it is overwhelmingly low. And I think, you hear the examples, Life for a Child from the GHU, the 10-cent mission, CDIC. We're doing these in relative isolation, and that's not great, right? So I think one of the things that we're excited about collectively, and I hope I speak on all of our behalfs, is coming together more about how do we amplify that. So the report sets something like the baseline, and then a lot of us have been engaged in a process around aligning the T1D partnership space. How can we make our whole greater than the sum of the parts? And then speaking for Novo Nordisk specifically, so we were the company who got the patent from the University of Toronto, and the commitment was to make sure insulin's affordable. And we're being candid here, right? So there's kind of two major ways to do access to a product in LMICs when it's not a just conventional market. So you can use partnerships, do things like advanced market commitments, volume guarantees, You can also do things like corporate policies on pricing. So we've had an access to insulin commitment where we've capped the price of our human insulin vials for most low and middle income countries at $3. The challenge there is, over time, it's created a market imbalance where it's been difficult to see competition come in. And so from a market perspective, this is something we really want to change. And we want all the voices at the table, very much including people with lived experience. How should we change this? One more quick thing. For us, we try to embed the thinking of health equity through our business value chain. So you mentioned innovation. As an innovative pharma, it's important for us that your voice and the perspectives are brought in early. So we're talking like really early, right? Phase 1, phase 2, and phase 3. And these two companies are actually doing better than Novo. If you look at the scores of how many advanced active access plans have been made post-phase 3, you have better scores than we do. But thinking about things like thermostability, reducing the dosing, et cetera, we need to think about it also in the context that 3/4 of people living with diabetes are in contexts that are really different than where we're sitting today. So I'll stop there and give other people the chance, but I think you've very much framed the challenge. And
I'm going to push on with John because
go. Yes,
we heard everything.
Yeah.
Great, thank you. John, I know you wanted to jump in very quickly. Go ahead.
Thank you for saying all of that, because I think you've put in a nutshell the massive problem, right? We could all drop a pallet of insulin anywhere in Africa tomorrow and leave it there and hope that it gets used. It won't, because we need to work on the healthcare training. We need to work on the regulatory process. We need to make sure people understand how to use it. So all these pieces are going to get us to the end of where you are. You have 3 companies sitting here, and I hope you understand this because it's a commitment from us, and I'm speaking on their behalf a bit, but we want to make sustainable access and continual access to good quality medicines and insulins particularly for the sustainable future. That's why we're doing things like tech transfer. That's why we're investing in trying to do the prices piece. Sadly, we can't do this overnight. You use the example of a child. A child should have innovation to insulins and so on. You're right. But we all have to come together collectively, and the partnership piece with governments to understand, let's accelerate the regulatory piece. Let's get how we can come together on the education process. They're all pieces of the building block to get to the umbrella you have. And we're all purpose committed to do this. I have a purpose-driven CEO who drives me on patient numbers, and that's what we're trying to achieve. So we're in this, but we need a collective action to make it happen. That child, sadly, doesn't understand, you're right, and doesn't care about the price, doesn't care about the complexity. They want to feel well. We're trying to bring together people, and that's why my comment at the beginning was, I want action. You want action, I want action. We want to take the pieces and do stuff about it and move the agenda. And, thank you for saying what you said, because it's quite humbling, and it hits the nail on the head.
I'm going to take one question here. Could you make it brief and succinct, please? Go ahead.
Sure. So I'm Sid Diarial with Vital Strategies. Just a question in terms of working collaboratively, like across companies, to help set up systems for holistic approaches that transcends the silos of companies or our specific goals, whatever they may be. Because I see, like, in the global funding scenario right now, equity as a goal. Perhaps there's things that your companies could do at the community level to help break the silos. Your example, Robert, of the refrigerator is a good one. So what you do for your company, are you talking to one another in the context of geographies that transcend the company's goal, so you make it more holistic? Over. Thank you.
Robert, you take that one. So
firstly, I agree. A lot of what we're doing is in silos. There are attempts to work together. We work in a highly regulated environment for good reason. I mean, we're making medicines that people inject into their bodies, and that they're regulated by regulators. So we are limited in how we can work together. We are from that perspective. But certainly, I think that more could be done, and we got to just work at finding ways in how to do that, to maybe collaborate better and collaborate more at addressing some of these common problems to the different companies.
How can you do better? Because I like that sentiment, but how do you do better?
I think it starts with talking to each other and having these kind of dialogues and getting in a room. Once again, I said, because it's a highly regulated environment, it sometimes is a challenge. Mentioned pricing being one of them. That that is something
you can't get together and talk about pricing. You can just not
have a discussion
about. Talk about pricing then.
Yeah. But there are other areas where I think you cannot at all.
Right.
But if I can just add, there's a lot of other therapy areas we can learn from. Yeah. This is not the first time there's been an access to medicine issue where you've had multiple, up to 5 manufacturers. So vaccines, HIV, sexual reproductive health, the list goes on. There's something around collective action where we need to be at the table, but we also rely on the voices to make sure that all our flashlights are going in the right direction. So people with lived experience completely transformed the HIV treatment and prevention access paradigm, right? And pharma followed in a way, and many companies, innovators and generics got together. So I think we need to also see that there have been some blueprints that have worked so that we can overcome some of the challenges that we have when it's just us in the room.
Sure.
And leverage those as much as we can.
You made Robert smile, so that was good.
That's the goal. That's the goal.
Yes, John.
One thing we can take it offline, but there is under the Bill Gates Foundation, there is a group called the CEO Roundtable, which 18 companies are part of. We're all part of this, and we're doing in-country workshops now with ministries, collaboratively together to do community healthcare worker training and look at all these access to medicines pieces. This is newish because the first time we focus on NCDs. We're managing to do the work on this. It's quite bureaucratic, but this is a massive step forward to where we were 18 months ago, and that will help move the dial. And the idea is we prove the concept and then we scale it up.
Final question for this panel. Yes.
So thank you very much. My name is Mark Baron. I'm a person living with type 1 diabetes, so using insulin that you produce for 34 years now. I participate in multiple groups of people living with diabetes, and I would like to bring some of the questions that those groups have, because I think nobody could be better than you to answer those questions. So,
can I ask you for one question?
Yeah, it's one question.
Yes.
I would just divide because I could not put them together, but it's basically one question. So, okay. And the question is. So we hear that not everybody is receiving insulin, but that the production of insulin is also limited. So if we would be looking to give insulin for everybody, would that be possible? And still talking about the production of insulin, we hear a lot that, and we don't know if it's true or not, but that the industry is reducing the production of insulin, especially human insulin, in order to produce more profitable medicines as GLP-1. So I think it would be a good opportunity also to clarify this. And the programs that were cited, they are marvelous. They are saving so many lives every day. So Life for a Child and CDIC, among others. But we know also that when people get older, sometimes they lose access, and it becomes a big challenge. If you have any recommendation regarding this. Thank you.
Thank you so much. All right. Will we get to the stage where we can have insulin for everyone, Rhonda?
Absolutely. My job at the moment is to grow our volumes by 3 times in the next 2 years. It's a little challenging, but that is really what our mission is, to really make sure that we're actually making more insulins. And we're very much in the insulins area. It's recombinant human insulin and the analogs as well, but recombinant human insulin for the LMICs tends to be the one that's actually mostly used. So a large volume of our production is going to be in that area, in both cartridges for the pens and the vials as well. So it's growing all of that capacity is what I'm trying to do. Working here in Europe, working throughout Middle East, Turkey, and over into the US as well, in terms of actually growing our network overall. So I'm going to try and talk to these guys afterwards and see what we can do.
Okay. Is it true that insulin producers are reducing the production of insulin? Is that true? Is that something that you could share with our attendees, or is that not what you specialize in?
No, I mean, as I mentioned a few minutes ago, we're investing in a $1.3 billion in improving our plant in Frankfurt for exactly the reason to increase capacity, but also increase efficiency in the way that we manufacture. So we can manufacture more quickly, and we can manufacture it at a better cost. That's the piece. So I think we're all continuing to invest in the future. And the reason for that is, it's the crux of your question is, are we going to be sustainable for the future in terms of keeping insulin manufacture for patients? From a Sanofi perspective, absolutely, because it's something we want to invest in. There's huge demand out there. There's massive unmet the needs in NCDs, in LMICs is huge, and I think that we need to match the two things together.
Robbie?
Yeah.
Go on.
So from a Lilly point of view, I can also state that we will continue to honor the supply of insulin. So you heard it from us. Despite what you've heard, we are committed to the supply of insulin. But what I can say is, over time, you may have changes in your business from a SKU point of view. So one kind of insulin or one delivery of insulin may change, and there may be some rationalization there. But the commitment to continue producing insulin is there. And also the model may change. And I just shared with you the model we chose, or one of the models we chose, is to partner with someone closer to the markets to bring down the cost of that insulin. Okay, we still supply the API, but it's just a different way of keeping the supply and making it more affordable and sustainable over time. So the model may change or where you get it from, but we are committed to the supply of insulin.
And Carissa, finally, if you can handle the aging question, is it possible to age out of being able to access insulin?
Yes, I just will finish the four and say Novo Nordisk is also committed specifically on human insulin. Our volumes are actually growing. Not to your extent, and let's definitely speak.
Yeah, but I'm behind. You're bigger, much bigger.
And I think the partnership model, so where along the chain is it right for an innovator to keep focus? API, is it all the way through? Do we look at API sales models, et cetera? So, but the commitment's there, and just to say, a number of us, we sit in a building that is shaped like an insulin molecule in Denmark. So insulin is not going anywhere.
So everyone's on their phone now Googling your building.
Yes.
Wow.
Google's aerial view.
All right, okay, very good.
And yep.
Do you know, it's such a pleasure to be able to bring you together. And I really thank our co-hosts for being able to do that, luring you with a lunch and then getting you to drop gems. I hope that you'll spend more time together and work on access and affordability for insulin. And we really appreciate you being on our stage this afternoon. Thank you very much.
Thank you, Penny.
Thank you so much. You know the audience would just want you to be on stage for an hour, but I'm sending you away. Because as you noted, in the audience, we have people with type 1 diabetes. We have people who've been living with diabetes. And so we've talked about the supply part of unlocking access to insulin. But what about the demand part of unlocking access to insulin? So I'm going to invite onto our stage Selassie Homenu. Please come from, where are you? You're at the back somewhere. Selassie, where are you? Come back on here. Come back to the stage. Come on to the stage. We welcome you. Bianca Hemmingson. Hello, Bianca. Welcome. Please come on and take a seat. And then also from Ethiopia, Dr. Abdulkadir Gilgelo. Welcome. Thank you so much. We have the demand panel. Sit right here. Hello, doctor. Please take a seat. Thank you. It's good to have you all here. Yes. All right, Selassie, so I feel that people with diabetes were rightly so. It's like we need to have this conversation, unlocking this access to diabetes. When people, this is an obvious question. But first of all, I want to ask you, just in a sentence, why was it important to be here in this conversation?
It's important to be here because we are the ones living the realities and we are the ones with the expertise. So to bridge the problem-solution mismatch, you need persons with lived experience to tell you the exact problem to find targeted solutions. That is why I'm here. Yeah.
Good. Great. Stating the obvious, but it's good to hear it out loud. Bianca, why are you here?
I'm here because I have the responsibility for the Global Diabetes Compact, the diabetes program within the World Health Organization, and it's mandatory for us to make insulin accessible for all, and we cannot do it alone. We need these dialogues. Despite being 100 years old, as you started to say, it's still unaffordable, unavailable. I don't hope we have this discussion in another 100 years. So let's...
Yes, please. Dr. Abdul Qadir, I know you are standing in for the Minister of Health for Ethiopia, but there is a bigger reason for why you're here, why it's important.
Thank you very much. I'm here to really share, to learn, and also to really join hand to hand for the call of action. Because, you know, where I come from, my country, when the insulin access is like, you know, a sun beyond the cloud, where, you know, where it is so close, yet it is, you know, richer.
You can see it.
Yes.
Right.
Where mother walk, you know, an hour to get an insulin only for a child to live, not to cure. Yeah, that's why I'm here.
Thank you. Selassie is living with type 1 diabetes. Thank you for coming here. When we were doing our prep, she was eating lunch. She's like, no, I've got to eat lunch. Brief me later. I need to eat lunch. So it's like practical. I'm seeing what it means to have type 1 diabetes right under my nose as we're putting this session together. Also, the General Secretary of Diabetes Youth Care in Ghana. If we're looking at solving access and affordability, as somebody who's living with type 1 diabetes, what is on your list of solutions that is clear to you that is not getting out there into the community?
So talking about access and affordability, I am going to pinpoint 3 major challenges that we face in Ghana and what my organization has been doing to try to solve these particular access problems. So the first we have is the regional inequities of insulin distribution, where based on your geographical location, you can have access to the insulin or not. So in the southern parts, it's easier to get access to insulin as opposed to the western parts of Ghana. And recently, for the past year, we've had insulin shortages. But that is not reflected in the realities of those in the southern parts because they still have access. And because of that, what my organization usually does is individuals or fellow warriors, we call fellow diabetics, type 1 diabetics, warriors, what they do is they take insulin from their personal coffers and then try to share or transport it to the northern parts of the country to ensure that their friends and their fellows can also have access to it. But that has not been as sustainable as it should be because you, the individual, is uncertain when you are going to get your next batch of supply. So sometimes it's very difficult to take out your own insulin to give to someone else. The next issue on access is on the availability. So they can be available at the healthcare facilities, but then again, especially in rural settings where individuals live hours away from the healthcare facilities, getting money to be able to have transport to the hospitals to get access to those medications becomes a problem. And we try to bridge that by providing transportation fares for individuals to be able to get to the hospitals and reach and get access to the insulin. But we have parts where there is no access at all. So what we try to do is try to send that to them. And that is where the issue of cold chain becomes a problem, because we usually have to transport it via the public buses. And these individuals do not know what insulin is or how to cater for it. So what this means is that even though we can procure it, the guarantee that the individuals going to get the insulin are going to get it in a very good state or ensure that the efficacy is not compromised is something that is a huge problem, because you have to travel hours in the heat in public transport to try to get them the insulin, and it becomes a huge problem. Then what we also try to do in bridging the accessibility gap is to try to educate and make people aware because we realized that in the rural settings, even when they have the insulin, they don't know how to use it. So it becomes a problem with the issue of compliance. So we try to educate them where we have a mentorship program where we call individuals. So every person or the executive structure has 40 to 50 mentees that we call every month to ensure that they have insulin supply. They've been able to visit the healthcare facilities. And if they do not, how exactly are we able to help them? And how exactly are we able to ensure that they have access and have the capacity to be able to deal with it? But I think the national solution that we have is on the health insurance, where the only insulin available is the premix, that's the human insulin. But then again, the issue that has, like, or the problem that we have to deal with that is that even though it is free and there is a national procurement of it, depending on where you live, especially within the rural areas, you might not have that at the local or district hospital because the hospitals may not be able to procure as much as they should in able to meet the demand of the local communities at hand. And what this means is that it results in rationing of the insulin available because it is very limited in capacity.
How do you solve those issues? Are they solvable right now?
They actually are solvable because we already have an existing structure we are working with trying to bridge the whole access issue with our own personal contributions. And then we do have volunteer nurses and doctors in the various regions who try to ensure that anybody that is diagnosed with type 1 diabetes gets on our program and is immediately helped is immediately helped in the essence that we add them to our system and ensure that they get supplied to that. The problem here is that we are limited in that regard because of the issue of funding and capacity, because we don't have as much human resource and as much financial capacity to ensure that we reach the very edges of the country that need it the most.
How much money do you need?
Wow.
Everyone's panicking now in the audience. Like, didn't bring my credit card. 30-second answer. How much money do you need? Have a think. Well, I taught Dr. Abdul Qadir, making insulin affordable in Ethiopia. How are you doing with that?
You know, in Ethiopia, the prevalence of diabetes is currently 3.3%, with currently the new screening, 40 million, according to our data. Ethiopia is currently reforming the policy and some of the programmatic change to include the diabetes care in essential health service package, and also national strategy to include the NCD guideline. And the supply chain improvement, I'm leading the supply chain of the country. We are making the insulin accessibility double the last 3 years, and also to make framework agreement, long agreement, with some of the company which already on the supply side. Within that, also partnering with Ethiopian Diabetic Association and like Chai Clinton and Life for Child. So we partner with them to have an access, consistent access for our children, for newly diagnosed of type 1 diabetic. In that regard, also, you know, some public-private partnership issues. In that regard, we are working some of the issue to make sure that the manufacturer involved to get some of the accessibility through our association. This is the progress that Ethiopia has, increasing the screening and also the demand, which is still unreachable, to come up with the numbers so that they will have an access to insulin with affordable price.
What are you doing better on, affordability or accessibility?
Both.
You're doing well on all of them.
Yeah, we're doing both.
Yeah.
But obviously, you know, the challenge with affordability, when we say affordability, still there is a challenge. As a supply chain leader, we have a problem with the price always, you know.
What price does it need to be? This is the most positive heckle ever. It needs to be free. This is an interesting business model that will not work if you go into business for yourself. But because we have the biggest insulin pharmaceutical companies in the room right now, they can't get together and talk about pricing, but individually, you can give them an idea of
practically
what's sustainable.
You know, practically, we don't talk about the price on the room with company here.
Yeah.
But the actual challenge we see in the ground is, I see many companies defaulted because of the price. I have a challenge many times because the price defaulted, because they say we can't supply you with that price. We can't supply you with this $2.5.
How do you fix that?
A different strategy. We go for donation as LMIC country. We go for partner.
It's sustainable.
Not sustainable.
Donation's not sustainable, is it?
Never sustainable. So what we do is we have a different strategy to use with partnership.
Yeah.
Partnership with, thanks to many of our donors, to have focus prioritized for type 1 through different associations that we have at the country. But affordability is still a challenge because I'm the biggest buyer in the country, but the challenge that we have seen is the price. Even in a critical time during COVID, I see that challenge is there for affordability.
Bianca, I'm going to bring you in. Bianca reminded me that I launched the Global Diabetes Compact for improving access to insulin. Thank you for reminding me. We are reunited again.
Exactly.
We talk about challenges, but in this session, we're talking about challenges, solutions to those challenges. That Global Compact is it, right? One of the ways.
It's one of the ways, hopefully, at least we do our best in order to solve this issue. Just for the one who missed the launch with Femi a few years back, it's online in case you want to watch it. But we launched the Global Diabetes Compact within the World Health Organization in 2021, and it has the objective to ensure everyone diagnosed with diabetes have access to equitable, affordable, quality diabetes care. So in order to achieve this objective, we have 6 different work streams, and I'll just tell a few of these activities that directly support access to insulin. One of them is that we, for the first time ever in the World Health Organization, are developing guidelines for type 1 diabetes through the life course. We will, within the next year, publish guidelines about type 1 diabetes management in pregnancy, type 1 diabetes management in children, as well as in adults, as well as in emergency settings. So being able for us as an organization supporting member states to give concrete advice on type 1 diabetes management will increase the uptake of type 1 diabetes protocols globally. Another thing that we are working on as well within the Global Diabetes Compact is access to insulin, and we have initiated pre-qualification programs. It's what also alluded to in the previous panel, where some manufacturers have went forward to pre-qualify their insulin. And we have actually also, it's not been mentioned much in this session, but just to say we also pre-qualify glucose meters because, you know, one thing is insulin, yes, the access is really poor, but glucose management, like being able to self-manage blood glucose, it's just so sparse and even non-existing in some countries. And it's mandatory when you're on insulin treatment and has type 1 diabetes. Another thing, another initiative in this access workstream is that we are developing an NCD forecasting tool, and Ethiopia has also been willing to piloting this, and we have been there a few times. But It actually has several modules as it's on NCDs, but it also has a specific diabetes module where we can help forecast the future need of essential medicines like insulin. So this forecasting tool will help support service delivery, but also future procurement. Hopefully it will reduce waste, but also ensure that you can do better price negotiating as a country, since you will know your future needs. One thing that is, of course, very important, and also one of the things why I'm so glad that we have this event today, is that we need all hands on deck to make this feasible and available. We work with a lot of stakeholders, needless to say, of course. We work with ministries of health, giving technical guidance to them, but we also work with a large variety of stakeholders, the private sector, people living with diabetes, and NGOs to help move this agenda forward. So that's overarching. I could talk more about it, but I think I'll end here due to time.
All right. I'm going to open up the room for questions. Let me just find out where the microphones are and the hands are. Microphone, please find a hand. Other microphone, please find another hand. Put your hands up. The microphone will come to your hand. All right, very good. I have one question, which I'm going to ask the panel now, which came from Robert. Robert, I hope I've got this right. How do we ensure that insulin brought in Africa for Africa stays in Africa? Did I get that right? Did I remember the question right? Yeah. Insulin that's brought, it's supplied to Africa, stays in Africa, doesn't go somewhere else.
Yeah, insulin that has to be produced in Africa and to be bought in Africa, as they said, need to have the regulatory issues, actually, which we could have harmonized it through our African Medicinal Agency with the price where we can have an access to the insulin which will be produced in Africa to be for African. Yeah.
Hello. Thank you.
Hi. My name's Renza Shabilia. I'm here with Breakthrough T1D, formerly JDRF, and also I work with DDoC as well. We've had a lot of big questions today. How do we fix this? And really, I've just got a comment and a thank you to Celesi, because what I want to say is that while we're waiting to find answers to those big questions, we have community, people with lived experience, saying we're not waiting, we're really impatient, and we're going to do that. And how absolutely incredible, how unfair as well that this falls onto people already living with a chronic condition to have to do this. But I guess if there is a question in there, it is how is it that we can make sure that the initiatives that are clearly working can be scaled so that perhaps we can actually find some answers to make sure that we are getting insulin to the people who need it.
Should I take it?
So,
yeah.
okay.
No, you can. You decide.
Scaling up the already existing solutions has been a priority, and it has been something that I think should be at the forefront, because I don't think we should start pilot care initiatives when there are already existing mechanisms that work. So aside my organization and what we do, I can list other examples like the Sonia Nabeta Foundation, and then also Pen Plus and what Pen Plus is doing in countries like Tanzania, Rwanda. These are actionable steps that have been taken, and we've seen the immediate impact of it. So with SNF, they have a clinic in Accra, and it provides free care, free diagnosis, free testing, free insulin, free glucometers. Everything is free. And it's working where we see that the glycemic control of the patients have improved significantly. So what this means is that all we need is the state's involvement to be able to scale it up on the national level. We already have the health insurance that caters for the accessibility of the human insulin. What we need is for them to be able to open up the insulin options to include the MDI regimen, that is the basal bolus regimen on it, and include the non-profits that are already existing, try to implement their models on a national scale and ensure that we have the reach that we need, because they have the funding and they have the resources. So that collaborative effort can ensure that we push for more actionable impact at the level, at the grassroots level. Yeah.
And Bianca, go ahead.
Oh, thanks a lot. I'm actually just complimenting what Emmanuel is saying, because it's true, it comes down to political commitment and prioritization. But I just want to just briefly mention that we back in 2021 actually had quite a historical milestone within the diabetes space, because we had a resolution on diabetes. And in this resolution, several member states, they commit to prioritize diabetes. And there are several 11 actions in total, so not mention all of them, but just one of them is like integrating diabetes into universal healthcare packages. So people with diabetes should not suffer financial hardship just because they have a condition where they need insulin for survival. Other thing, there was also asked for the World Health Organization. One of the asks was to develop global coverage targets for diabetes, which were endorsed the year after, in 2022, and there are 5 targets to be achieved by 2030, but just I want to highlight one of them for this discussion, and it's the 5th target that says that 100% of people with type 1 diabetes should have access to affordable insulin and blood glucose self-monitoring. And member states, they also endorse the targets, so member states, they have in principle committed to this, so now the work is to stick to this commitment and give it priority.
Ethiopia is working on the, I'm the member of the parliament, and Ethiopia has introduced the health insurance with currently half of the population enrolled in health insurance, which many of our essential services to be covered through that health insurance coverage. That's one thing Ethiopia is doing as a policy, changing through reaching out those in need for an access to diabetic care, and including in the essential service and with NCD forecasting, which we will have the upstream access to insulin through our procurement agency. That will align apart from our partnership support through different partners that is supporting Ethiopia, which we're really glad and always supportive and thankful to them. Yeah.
Yes, thank you.
Thank you. Brendan Shaw from Shoreview Consulting. Firstly, just want to make a comment. Thank you for the panel and the organisers today. I think this has actually been one of the best sessions at the World Health Assembly.
Sorry, we didn't hear that. What did you say?
This has been... I'll say it again.
My hearing has temporarily relieved itself. Could you just repeat that right into the microphone?
I'll say that again. This has been one of the best sessions at the World Health Assembly. And the reason I say that is because there's a lot of the sessions have been about crisis and lack of finance and those sort of things, and people, hand-wringing, but this has actually been quite an edgy discussion on access issues, and we've had patient groups in the room. Congratulations to the companies for fronting up and being here, I think, and then the discussion just here as well. So I just wanted to say it's been a good session. I guess my question is, building on that a bit, when you look at the issues, there are some issues that companies individually are going to be able to solve and work on. We heard some of that. There are probably going to be some issues that the companies can work on together to varying degrees. But then there'll be other issues, and some of them we've just heard about, that other stakeholders are going to have to work with industry and other stakeholders to solve. Things like infrastructure, supply chains, middlemen in the supply chains adding costs on, and those sort of things that the companies aren't going to be able to deal with on their own. So my question is, how do we take some of that collaboration to the next level? How do we start identifying the different tasks and strategies that those different players can do individually and together? Because it seems there's a lot of them, and it's a complex problem to have. So how do we sort of take it all to the next level and start identifying who can do what and how we do it together?
Well, that's such a good question. Bianca.
Thanks a lot for that question. I actually think it's an initiative that is already trying to be ongoing right now on finding a combined solution across the pharmaceutical companies. And I think when we hear the companies speak here, at least, that there are commitments and ideas on how to do it. But I have to say, of course, the affordable insulin is, I say, it's a human right. It's something that every pharmaceutical company, they should commit to, because people, they're dying because they cannot reach their insulin. So I know there are some initiatives ongoing on trying to find a healthy market model to ensure people with diabetes, they receive insulin. But in addition to that, we heard there are a lot of other obstacles that are not just due to the cost, but also even if they were for free, there would be challenges. So it needs like a complete health system approach as well. But for sure, the cost of insulin needs to go down. Thank you.
Right. All right, this is a hard question. It's like, how do you get all of the important players together to work together? What have you seen that's worked?
You know, no single actor can solve this, alone.
Yeah.
You have to be together in investing, together in supporting, in innovation and transfer, so that every child has an access to insulin. Whatever they have, it's a human right issues. So it's not should be privilege. It has to be a human right at every level.
Sure.
So the company, the manufacturer, the demand side has to work together to make sure that insulin is accessible to every
All right, I hear that. Selassie, I'm going to go to you because I feel like you've got such command over diabetes because you're an advocate and also someone who lives with type 1 diabetes. If you could do whatever was needed to be done, and I hear you about why does the community have to come up with the answers, what would you suggest to get that collaboration to really happen?
What I would suggest is, first of all, there is already the acknowledgement of what each stakeholder can do and what limits us in our capacity. So we do realize that the state bodies or the governmental bodies are responsible for policy, but then when it comes to implementation, persons with lived experience have a better expertise in that field because we are most approximate to the actual realities, and we are the ones that can easily ensure that the model is implemented in the sense that there's already that communal trust. So the issue of compliance is easier accessed on our side.
Okay.
And we already have the advocates who are ready and willing to do that. All we need is for the state and then the other important actors to just come and we will do the work. We've already been given the work and we are doing it. Yeah.
You did not get an answer to your question because it is very, very difficult. James Reed, who's going to be doing the closing remarks, will have an answer to your question. He thought he had it all planned out, but no. Final question is going to be a brief one, succinct one, please.
So it's my name is Saba. I'm from Eli Lilly and Company. So building on the question that was asked, there's a lot of conversation around access from the manufacturers of insulin. But my question is, what's that ownership at a country level on understanding the epidemiology of the disease in country, understanding what the investments countries have to make in terms of supporting the population that has diabetes or needs access to insulin, and how do you also then create a model of care, right, that is sustainable from an access perspective, not only to urban populations, but to rural populations, because we heard that from Emanuela, right? And so the idea is, what is that shared responsibility? Because there's a lot of an ownership or an access challenge that's here in the corner, but my question is to the panel or to other multi-country, what's that country level ownership where we hear of health as an investment and what we should do for the population of the country?
Why did you ask that specifically?
Because I think there's a lot of conversation on what we think of, ministries of finance are not talking to ministries of health, they're vice versa. But at a country level, shouldn't they be talking about bettering the population and what are the challenges that are facing in the space of non-communicable diseases with diabetes and obesity being sort of the leaders in terms of what we see, what's happening in countries in general, whether it's LMICs or in high-income countries, right?
And where are you from?
The US.
No, I didn't mean geographically. Your affiliation?
The organization?
Yes.
I'm with Lilly.
Okay, great. All right, thank you. That question is an entire session with country ministers of health, at the very least. But I am going to share it with you to see what insight you might have. But I am aware that you need more people to answer this question, plus James Reed, who's just coming up in a moment, who will, anything that we haven't addressed, he will address. This is a hard one. It's such a good question.
Yeah.
I'm not even going to summarize it. You summarize it in the way that you feel you can answer it succinctly.
Well, as Ethiopian, the country ownership for this is Ethiopia already prioritized the NCD with opening different departments for NCD and policy level and also programmatic level as one of the pilot country with NCD forecasting as well as a strategy putting into the health insurance level and strategize as priority in the country strategy. So the country ownership is matter more because the funding, the support might not be sustainable. We have to put it in a country strategy where it will be sustainable. So Ethiopia is doing that to make sure that the country ownership is taking what to be for implementation as a strategy. So Ethiopia is doing that.
That was a great question. WHA 79 needs an entire session so you can really get into the nitty-gritty of that. But for now, I say thank you so much to the Demand panel for your time, for your insight, and for your excellent questions as well. Many thanks.
Thank you.
Thank you. Thank you to all of our panel speakers. We started with opening remarks from one co-host. We will end with closing remarks from the other co-host of our event. He's also the man with all the answers to any questions where we didn't quite get to the answer. He is the Type 1 Diabetes Program Director for the Helmsley Charitable Trust. He is James Reed. James, thank you so much. We're looking forward to your answers.
Hi, everyone. Thank you. I really want to start with thanks to our co-host, Access to Medicines Foundation, and frankly, to you all. I think this has been a really interesting conversation within the panels, but also between the audience and the panelists. And I think really want to thank you guys for being honest and challenging each other. And that's frankly how we get to that question of unlocking insulin. We've been privileged to hear, I think, from a very diverse group of perspectives. We heard from the pharmaceutical organizations that are working to strengthen supply and sustainably lower costs. They offered some challenges that they're facing, but also some of the key solutions that they're advancing, acknowledging their own limitations. At the same time, I think we heard from government leaders, multilateral organizations like the World Health Organization, and people living with diabetes like the incredible Selassie, who brought a lot of energy on how we drive delivery, policy, and I think most importantly, accountability at a country level. And again, really good questions and challenges to that panel about how they could be doing more. When we started the conversation, we started out with some framing from Claudia about the burden of the disease and a reminder that we've had insulin for over 104 years. And yet, we're not reaching everybody who needs it. It's a pretty pessimistic view. It's challenging. I think it's really well known that insulin is a challenging topic, deeply entrenched issue. But what I'm walking here away is really with some optimism. And I'll be honest, I had an inside view of what was coming, but I was still surprised and learned a lot while I was here. I walked away with some issues that we talked about, things like supply challenges. Pharmaceutical organizations are working to plan ahead about how they diversify supply, improve local manufacturing, and I think, importantly, coming to the table differently and together. I like the challenge from John at the beginning that this isn't just a conversation that needs to end here, but rather one where we move into action, concrete. And I think good questions, again, from the audience of how we continue this. And I know all the organizations, including the pharmaceutical groups, have already been engaging practically on how we do that. We also heard challenges about issues on the demand side, about how there's not reliable forecasting, there's not enough guidelines in place, there aren't providers being trained. If things are left in a country, how will they reach people? But again, we're hearing momentum and solutions in that direction. We're hearing about progress of the World Health Organization with global technical goods that are setting standards and empowering countries to adapt and bring those into their national strategies. Ethiopia talked about their ownership of that issue, how they're making progress. Are they there all the way? No, but there's a strong commitment to make it and to reach those rural communities. And I think most importantly, we know that there's a strong safety net that needs more investment, community-based organizations, but are really keeping people together and moving forward despite the challenges and despite the fact that we could be moving quicker to meet them midway. I think what's clear today is that there was alignment that each of us bring different strengths to the table, and we need to continue recognizing our limitations and where we can add into the bigger picture. We want to talk a little bit about what we at Helmsley view as philanthropy's role in this. We believe in funding efforts that bring together the right partners to solve complex problems like access to insulin, which again is not the full package of diabetes care. Philanthropies like Helmsley can play a unique role. We're not just a funder, although that's an important part of it, but we work as a catalyst, a connector, and a champion for bold, new, collaborative action. We recognize that philanthropy is really important in de-risking new ideas. I heard this the other day right from a ministry in Tanzania who said that often governments can't take the leap of faith to try something new, but we can partner with philanthropy to identify a need and help test out something as long as it's aligned with the priorities of the government. We can invest in enabling systems that are often underfunded, testing care models like the model Pen Plus that Selassie mentioned, deploying proven tactics to form healthy markets, and supporting underfunded community-based organizations that deliver localized services when the public system isn't quite there yet. We can help convene partners like we tried to do today, and thank you for heeding our call, so we can co-develop shared access strategies that are paying particular attention to the insights and views of people living with type 1 diabetes and type 2 diabetes. And I thank the many voices in the audience who added to Selassie's seat on the panel. But none of this really works if we don't work together with urgency, with coordination, and a commitment. I think what we heard clearly, again, is to long-term sustainable action. Access to insulin isn't just a supply chain problem or a financing issue or a government commitment issue. It's a systemic challenge with barriers extending from research to rollout. We're seeing progress, but ultimately, again, 104 years after the invention of this product, it's still not reaching everybody it needs. In some ways, insulin is a true indicator of how well we're doing at delivering innovation. I'm optimistic that we're finding momentum and creating pathways together, and I'm optimistic that if we can solve this seemingly intractable challenge, we actually set ourselves up to deliver more innovations more quickly for those who need them in really any difficult essential medicine situation. So I want to leave you all with a request to commit. Let's move past pilot projects and fragmented fixes in our own silos and our own partner communities towards a coordinated and sustained action that ensures that insulin and quality diabetes care is truly accessible and affordable for all. Thank you.
The end. Thank you so much, everybody. Thank thank you for being part of the best WHA 78 session as agreed by one of our attendees. Have a great afternoon and thank you for joining us. Take care, everybody. If you have a headset on or a microphone on, please report back here to audio to take it off. Thank you very much. Have a great afternoon.